Hello and welcome to the STFM Faculty for Tomorrow webinar series. My name is Emily Walters. I'm staff here at STFM, and I'll be facilitating today's webinar session called Using the Brain Rules to Blow Up Your Lectures and Make Learning Stick with Dr. Michael Tuggy. This is webinar 9 out of a webinar series presented by the Faculty for Tomorrow initiative, and you can find recordings of all the previous webinars in this series at stfm.org under online courses and then click over to the webinar page. Faculty for Tomorrow is an initiative by STFM to address the shortage of family medicine faculty. Its goals are to provide resources and training for new faculty, including those moving from private practice to family medicine education, to identify and support young family physicians with leadership potential, to ensure that the leaders of institutions understand the time and competencies required to be faculty, and to expand STFM's formal faculty recruiting efforts of residents. Faculty for Tomorrow is supported by the American Board of Family Medicine Foundation and by the STFM Foundation. Dr. Tuggy, would you like to introduce yourself to our audience?
Yes, I'm Mike Tuggy. I'm a former residency director for 15 years from the Swedish program in Seattle, and now I work in a small community, rural community as a family physician again, working for Confluence Health. And my other roles are serving as the Vice Chair for Family Medicine for America's Health, which is working a lot on our health reform and payment structure within family medicine. And then also I'm serving as the Senior Editor for the Residency Curriculum Resource, which is providing interactive lecture content to residency programs as they're training their residents.
Wonderful. We're glad to have you here, and thank you for creating this presentation for us on such a critical topic for education. I'd like to invite the audience. If you want to use the webinar chat box, you can submit questions at any time during this webinar. We will pause to answer your questions at intervals throughout this presentation. And thank you also to those of you who answered some questions for our pre-webinar survey, which is always helpful to get a sense of our audience as we tailor these presentations to you. So now we'd like to use a live poll for all of you who are here to give a sense of who's in the audience today. I'm going to go ahead and launch it. We're just asking you about what your professional role is. And you can go ahead and vote right now to let us know who you are and kind of give us an idea of who we're talking to. So the votes are coming in. Looks like you all have figured out how to get at that, which is great. Continue to let it go just a little bit more while the rest of you let us know. And I'm going to go ahead and close the poll and share the results with you all. Okay, great. It looks like we have pretty strong majority of residency or fellowship faculty at 74% right now. We have 20% who are medical school faculty, 4% who are residents or fellows, and of course 2% who are community physicians and or preceptors. So thank you all. We're glad that you're here. And should be good to go. Okay, over to you, Mike. Thank you.
Okay, thank you very much. So this is a topic that's near and dear to my heart because as I was working as a teacher in family medicine and then eventually a director, one of the things that I saw a lot was just a lot of variation in how people would present topics to residents. And as I started to try to study how is it that we actually learn, and fortunately made some contacts with some neuropsychologists and in our Seattle area who were deeply involved in learning in the brain, I really felt that there were things that we needed to learn about as faculty members in order to really change our teaching game and kind of ramp it up into a new level. So one of the first questions I like to ask people is, what makes a great lecture? Is it the dynamic delivery and the pizzazz of the slides and the content? Is it the entertainment factor of it that gets people's attention? Is it humor that you use in your lecture that gets people's ideas going? Is it the ideas that have power? Is that what draws residents into learning better? Or is it even the suspense that you can have within a lecture? And I've seen a lot of lectures done which have a lot of this type of content where it feels like there's a lot of kind of entertainment value to a degree. And what ends up happening, though, is that sometimes that content does not actually drive learning, and that's what we're going to talk about today. Is because our goal of giving a lecture is not for us to entertain our audience; it's to actually have our audience learn. And we're going to talk about different cues and different methods that we can actually do to make that happen. So think of a great talk that you've heard in the past. Think back of a great lecture you may have had. Just imagine that speaker up there on the podium talking to you. And can you remember anything specific that they said? Is there any particular teaching points that you could walk away with from that great talk? And I certainly have heard great talks before where I walked out of the room feeling like, wow, that was really great. The problem is sometimes, though, is yet we may not be able to remember what the key concepts were that person was trying to bring across to us if they don't deliver that talk properly. And sometimes I have heard lectures where I thought they were excellent, but then 2 weeks later, I couldn't remember hardly any of the content at all because I was more entertained than I was actually triggered in learning. So attention span is really a big issue for us. How often, and what attention span is you think about this, is how often do we need to change the stimulus to our brains to keep our attention? And if I was to ask, what is an average attention span for most people, based on the brain science that we have now, it's really only about 10 or 15 minutes. And if you don't change the dynamic of the way that you're delivering the content to a learner within that 10 to 15 minute time frame, you begin to lose the audience, which is not very long. And this is kind of a typical attentiveness model looking at attention over time. And if you look at this with minutes on the bottom and the kind of the attention span being at the highest point during the first 15 minutes, it begins to drop off dramatically if you continue to drone on and just continue to talk with your learners without getting them more engaged and changing the learning technique you're using for that person or for that group. So within 45 minutes, the audience is kind of at a dull state of learning, and then there's an uptake in attention because they're so anxious to get out of the room. So this is unfortunately the way our brains actually work, and I think many of you who do teaching, you can see this kind of energy within your time if you have an hour-long lecture planned for your residents. So just do a quick self-assessment here. In the past year, have you given didactics where, and these are yes or no questions, a resident falls asleep during your presentation? So again, you can just take this on your own notes on the side. We don't want to share these answers because it's all very embarrassing. A resident is texting to plan that evening's events during your talk. You ask a great question and you get this blank stare in return from the entire audience. Or number 4, have you had residents complain that they had to work too hard during much of your presentation, or during your presentation, they had to work too much? So there's different answers to these questions I'm sure each of us will have, but I do think that how our residents act during our lectures gives us a clue about how engaged they really are. So how good is our retention rates? If you have key points that you want to pass along to your learners, if you give a traditional lecture, and one of the questions we asked in the pre-survey was, how many slides do you typically have in a lecture? And Emily, could you go ahead and put that up, that question up for a poll for the audience? Like, what's the typical number of slides our presenters or participants have in a lecture that they give?
Thanks, all. I can see that you're submitting your votes, and the answers are coming in. We've got kind of a tie right now. We'll see where this kind of lands for us. Okay, we've got a majority of you have gone ahead and voted, so I'm going to go ahead and close the poll and share the results. Yes, it looks like we've got 35% use less than 20 slides. We've got 53% landing in that middle range of 20 to 40 slides, and 11% with more than 40 slides in each presentation.
Good. Okay, so all that slide content that we put together on a typical, if you look at how typical learners learn with traditional lectures, they retain about 10% of your content, of your key concepts that you may present to them if you're doing this typical didactic format. And I say it's 10% on a warm day, and our didactics room was actually quite cold, so I think our learners were getting even less as they were shivering away in our cold lecture room that we use in our residency program. But the real question is how can we engage our learners actively in a way that allows them to retain and use what they're experiencing from your teaching. And if you think about what learning is, it's really about the ability to hold on to concepts and then be able to use those concepts. And learning is retrievable memory that can be used for problem solving. And that's what our ultimate goal is in medicine, is we want to provide them with content and material of key concepts that they can then use to problem solve when taking care of patients. And the question is, can we learn and be entertained at the same time? Is this something that we can do? And if so, how can we engage our audiences in both those activities so that they stay fully engaged in the process of learning while we're spending time with them? One of the things that I think we struggle with is, in training programs, is having enough time to deliver all the content we would like our residents to learn over a 3-year period. And this is a huge challenge for every program because there is so much to learn in medicine. But we also want to build a skill set of conceptual problem-solving tools for our residents to take with them in their career so they can continue to learn throughout their entire career and have good problem-solving skills when they're taking care of patients and managing their practice. So think of learning as engagement and not entertainment. It's really the key point here. So one of the things about this process for me in undergoing this, understanding how we learn, was to get to know an author of a book called The Brain Rules. His name is John Medina. He's a neuropsychologist, and he has done a tremendous amount of work. He's written several books now and does lectures for major corporations, the Air Force Academy. In fact, it's hard to get him now booked to come and give you a talk, but he actually came to our residency program, did a faculty development afternoon with us. And just going over the brain rules is really an important part of understanding how everybody learns. And if you haven't read this book, I would highly recommend it. It's a fun read. It's only about 180 pages, but it will help you understand how it is that people learn and how to think about that as we are training residents. But his key points are that you have to engage with the content and to get a conceptual understanding of what is being taught to you. So engagement is really key. You should use visual or hands-on learning if possible in any circumstance, because the more stimulation of the brain that we actually do in the process of learning, the more people retain. And this multisensory input is really a key way for enhancing memory retention. And then the final thing is that you must use the right timing rules when you're giving your content to your learners if you want them to remember anything at all. And this is very interesting because it is a key thing that we've never really been taught as teachers, but it is really important for how our brains work and retain content and to make us more efficient at learning. So what do we know about timing and memory and retention? This is really an important thing I want you guys to walk away with today. First is that you have to repeat a concept or a key learning point in some way at least 30 seconds after you first present it. So you need to, it needs to be repeated for the learner so they either hear it again or they say it themselves or they mull it over in their minds within 30 seconds of first hearing about it in order for them to begin the memory process to put that in long-term storage. So again, you have to repeat the content that you're teaching in some way within 30 seconds in order for them to initiate the memory process. After that, if they repeat it again in their minds at 60 to 90 minutes in that time frame, if they think about the content again in that time frame within that 60, 90 minutes, what happens is when they go to sleep that night, their brain begins to activate it during their sleep cycle, and they will repeat it over 1,000 times while they're sleeping. So this is how we begin to build long-term memories and put concepts into our long-term storage that we understand to be important. And if you do a morning review the following day, you boost the retention by another 10%. So you can basically, what we can do is we can take learning and retention of our learning from a 10% efficiency up to about a 60% efficiency of retention of core concepts if we do these type of timing things within our presentations that we give. So this is really a key concept that is critical to understanding how our residents are going to retain what we teach them. So are brain rules important? There's a lot of studies looking at learning, and they've come to very similar conclusions that John Medina does in his book. But what actually, it actually makes sense to us when we hear about these rules. I think a lot of us realize, well, this seems to ring true. That if I repeat things, I tend to remember them. It seems like there's a sequence to that repetition that makes me remember things better. But the hard part is that it's actually hard to kind of teach this way. It feels like it's not a natural way that we've seen teachers teach, and so we try to emulate what we've seen in the past. And in reality, it's a much more interactive and engaged process than having somebody standing in front of the room and having 30 people paying attention to them for that hour-long block of time. There are a lot of temptations that we have, I think, when we're teachers. We want to give learners all the information that you think they need in that time you may have with them. And oftentimes we focus a lot on factual content versus the meaning and understanding of key concepts. And so you think about things like hypertension, how we teach about hypertension. We may want to throw out a lot of facts about which drugs to use and which type of patients and which type of risk factors and who you would favor. But I think that if we think about key concepts in hypertension, which is that there are mechanisms in which people develop hypertension, those are physiologic, and sometimes the physiology of some of the content is much more important than the actual facts, because those facts will, as we know, can change over time as to what recommendations are. But the concepts for how to treat the hypertension is actually really much more important for them. And what we tend to do is then it's death by PowerPoint. We throw lots of information, way too many slides, and the learners are overwhelmed by the content of the slides, trying to read it while you're talking instead of interacting with it. So what do we need to change? We need to change the idea of what your lectures look like. We need to think of the value of your teaching time. I mean, your teaching time is so precious that you do not want to spend an hour with your learners and have them only retain 10%. We want them to maximize that learning engagement. In interactive teaching models, which have been, which there's a fair amount of literature out there about how to do this, but these models can be applied to pretty large groups. I've done interactive teaching models with a group of 200 learners before. In fact, this slide presentation today, we're going to step out of it and do some interactive learning. And if you were in the room with me, I'd be making you work in groups of 2 or 3. And in that process, you would become deeply engaged in the material. And even though it feels like it might be chaotic, as the moderator of that kind of session, I can tell you can have a large number of people working together and learning in an active way and still maintain control of the crowd and get them to learn well. So a professor at Harvard, his name is Eric Mazur, is a physics professor, and he was teaching the freshman physics class, and he's one of the first people to kind of really blow this up in a major institution as far as how to teach. And he found that he got all these awards for being a great teacher because he could give these very dynamic lectures, and his his students really thought he was a fantastic teacher. The problem is that when he would actually test the learners, he felt like they really weren't learning the core concepts very well. The scores that he would get back would be very disappointing to him. And he was trying to put this together, like, why is it that they aren't actually learning, even though they say I'm giving them a great delivery in my lecture? So he started changing his first year freshman physics class into an interactive learning model. And these classes are huge with several hundred students in the class, and he started to have them work on problem solving and working in small groups of 2 to 3 or 4 people at a time to answer questions during his hour of teaching, and he found that there was a marked increase in the ability to answer questions on tests afterwards that demonstrated the conceptual understanding of the physics he was teaching. So how does this look different for you? So you move from being a lecturer to a learning facilitator, and this is a really fun transition. And it sounds like 35% of you or so are actually doing much more interactive learning. But I think if you look back on what you're doing now compared to when you were just trying to give a talk in front of a group of learners, that interactive facilitation is much more engaging for you, and also really draws the learners into activities that will enhance their learning. You can also expect students to come prepared. So assigning pre-readings, if they have background information, is something that we should be thinking about doing in advance, so that when you come together to learn, you're not coming there for them to hear things for the first time, but to actually engage with it, problem solve with it, and then retain it for long-term use through your exercise you're going to do with them. So what does this look like in practice? What this means is that you're going to have less slides. And for your typical presentation, I think if you think about having 20 or less slides, that's a very good sign that you are going to be spending much more time engaging your learners than just dumping information on them. Let the papers they read prior to your session be the thing that actually provides them with the background information that they're going to use during your learning session. Your slides are going to be more based on case-based questions, putting up cases that challenge them to problem solve as part of their active learning process. We need to get skilled as teachers and as lecturers to decide what is it that my key teaching points are. What are my key learning points I want them to walk away with, not just throwing them a lot of facts. And then make sure you have structured your time you have with the residents with a clear plan to summarize and coalesce the learning points at the end of your lecture. By having that as part of your structure, you will be sure that you are teaching the key learning points, but also giving them that 60-minute review cycle that we need to have to put things into long-term storage at the end of that hour. So let's take a look at what this looks like. I'm going to be pulling over my Prezi presentation, and I used to have a handout for people to use to go through this with me. So it's typical for my kind of active learning sessions is that I will provide the residents with a handout which will have the cases on them, and it'll have questions for them to answer during the case interaction time. So building that into your lesson plan to have a handout for the learner just to answer questions and to fill in notes on their own, that actively engages them in the process of problem solving. So we're going to step out here. I'm going to flip over to a Prezi presentation, and hopefully this will show up on your screen. So I'm going to drag that over there. Pop this up to full size. Emily, is this showing now the tuberculosis and HIV Prezi?
Yep, coming up. It just went to full screen.
Good. Okay. So this is a typical example of how I've taken a talk, which I think used to be a lot of information, and made it into an interactive presentation. And I think one of the things that Prezi does is it provides this motion which keeps people's attention visually, but it's really the content of what you put into each of the individual slides here that will drive the learner. So starting this out, the first thing I do is show the key concepts. And again, where I've done this before, where I've had an active, a live audience, we've actually stepped in and actually started working on the case. So I'm gonna step in and pretend that you guys are my residents, and we are going to be talking about TB and HIV. So the key concepts are: TB is an indolent disease that is a two-phased infection. In the immune-compromised patient, its presentation is quite different than the immune-competent patient. Cough X-ray changes may not be prominent in AIDS patients due to the lack of inflammatory response. TB is commonly an extrapulmonary infection in HIV patients. So look for other loci of infection, such as the brain, the pericardium, and the bone, when these patients present to you for evaluation. The mainstay of treatment is RZHE for 2 months and then 4 months of RH. Many variations of protocols exist, but this is core to treatment. And then the last concept is to understand what IRIS is, which is immune reconstitution inflammatory syndrome, which can be fatal if not managed properly. So I've just given 5 key concepts, and now we're going to have to spend time diving into them in this teaching process so that we can actually learn what they are. And this is the way that I will induce repetition of these key concepts as we are taking the learners through this learning activity. So case number 1, shortness of breath. 37-year-old East African male with shortness of breath, tachypnea, and marked work of breathing is noted for the past 3 days. He also reports fatigue and weight loss for the past 3 months. He's reviewed his system. He denies cough. He's positive for subjective hotness of the body as he describes it. No sputum production, no diarrhea, denies any history of any STDs. Let's dive into his physical exam. He's afebrile, his blood pressure is 90/72, pulse is 110, respiratory rate is 52, temperature is 40.1 centigrade. O2 sat is 41% on room air. He's arousable but not very coherent, thin and wasted in appearance. He has bilateral rows and retractions. He's tachycardic with irregular rate and rhythm. On his neuroexam, he has normal DTRs, no focal weakness or sensory changes. This is his chest x-ray. Now, in groups of 2 or 3, I'd like you to sit down and discuss among yourselves what are the top 3 infections in your differential that could cause this clinical picture. So again, I would give the learners a few minutes here to step out in groups and talk about what their differential is for this type of picture. And then we're going to dive into discussing this. And what most groups come up with is tuberculosis, PCP pneumonia, or community-acquired pneumonia based on this X-ray. So the question is, what features of this presentation, the whole patient presentation, are most suggestive of tuberculosis? What exam findings are most concerning, and how does this inform your differential? So what this does, these questions do, is now they have this concept in their mind that TB presents differently in immune-compromised patients than immune-competent patients, because that's one of the early concepts that we've had. And now I'm presenting them with a case of somebody who's obviously quite sick, comes from a part of the world where we know that there's more HIV, so they're already thinking this person probably has HIV. And now I'm asking them about what are the features that are suggestive of tuberculosis. And what most people expect would be a fever, cough, sputum production, and this patient only has fever and weight loss. So what it's starting to do, it's starting to help them see that an immune competent versus immune compromised patient does look different if they have tuberculosis. And this is the process that we go through in this whole lecture of challenging what they expect with new learning about how different this looks with patients with HIV. So I'm going to step back out of this presentation again and get back to our slides. But I hope that gives you just a glimpse of what these types of questions are and how to design them to really engage with your learners. So one of the challenges of teaching with the brain rules is it really takes the eyes off me as a presenter and puts the learner with hands-on material. The goal is to have them have to answer questions, have to process the information and come up with conclusions and extrapolate to those conclusions, which forces them to learn the concepts. And so this is where, as you're thinking about what is it I'm going to be teaching today, to really come up with a list of key concepts at the beginning of your talk, because those concepts really pull it together, and the kind of the ancillary information and the facts will feed into that. But as we all know, facts can evolve over time as far as how we understand disease and how we think about treatment and management, as far as what the best options are. The attention span is a hard slave to master, and I think when you look at how to design your say you have 30 minutes or 45 minutes or an hour block of time with your learners, you want to mix up what they do So you may do a short 5-minute introduction and then give them some questions to answer based on a case, and then jump back into some more teaching around that particular question, and then you jump back to the next question for them to answer in a small group, and then you may have them make a list of a differential diagnosis on their own and share that with the group. So you're just going back and forth between your teaching and their interaction several times during the time you have with them, so that you keep them fully engaged. And if you do that every 10 minutes or so, you're going to allow them to stay fully re-engaged, because every time you shift techniques, you're going to regain their attention again. And this whole thing about repetition, if you have a key concept that you want them to learn, it's really important that you actually repeat it within 30 seconds in some way. That you share the concept, you say, here's an example, and you go back to what the concept is. And even if they can articulate it on their own, that's even better for them as far as learning it long term. And I think one of the things I'd like to say is the problem with repetition is it seems repetitious, and it is. I mean, you have to repeat things several times in that teaching session you have in order for them to begin the process of retention. It does seem repetitive, but that's okay. This is the way our brains work. So then the last thing is, it's really important at the end of your time that you have a summary step. That where you use the concept of time repetition in order to begin that memory cycle process of putting into long-term storage. And I think one of the tough things is if you have several lectures in a given afternoon, like we used to have 2 or 3 lecture topics in an afternoon, oftentimes 3 45-minute teaching sessions, is that somewhere in that 60 to 90-minute time frame, we wanted to give those key learning points back to the residents for them to think about. So oftentimes, if we had an afternoon, we would try to theme it in one particular area. So for instance, maybe we're talking about HPV disease in women, and how do we manage cervical cancer screening and abnormal cervical findings on exam or on pap smear. But we would try to use those related topics to help reinforce what the first lecture was doing. And then we also had the idea of sending an email out to everybody to review that evening with the key concepts written in it, so that when they left the lecture room, they would get a tickler that evening before they went to sleep with the key concepts as well. Not everybody was doing that in our program, but it was one of the things that we wanted to try to encourage, was to have a summary text or email just to say, hey, remember, these are the key things you learned today. And that would be a very slick way to help trigger more of the memory cycle. The summary step gives you a chance, too, to highlight some salient learning points in the group discussion. This is something that I found was so interesting to me, that I would have some key concepts I want the residents to learn, and I would often have R1s and R2s and R3s in the room working on problem solving together. And the R3s, many of them would have had experience with those types of patients and would share additional learning points that I may not have even thought of, but they would help enhance the key concepts that I was trying to teach. And this this kind of reinforcement from this active learning process in that group discussion really helped engage more, I think, more subtleties and more kind of finesse about how we manage some of the medical conditions or make the diagnosis for various problems that we were teaching about. Anyway, the summary step really does give you that 60-minute opportunity to actually do the repetition that people need. So what have we just gone over? What have you just learned? So effective teaching must actively engage learners. And there are many ways to do this, but the most engaging way is through clinical problem solving and case-based teaching. There are visual tools that you can use, using images, if I was to ask the audience, what are some of the images that you've already seen in this lecture that I've given you? Some of you will remember different pictures that I've already shown, and those were put up there intentionally. I was trying to distract you with the visuals, and I think you may be surprised how many of the images that you have seen in these slides you could actually remember, and you probably don't remember the word content nearly as much. But using images, especially ones that are moving, so video is a really powerful tool for learning, actively engages more parts of the brain to help people remember things. It's very, very important to think about teaching concepts more than facts and using those cases to do that. And so outlining your concepts is a key step. And then finally, the timing rules are really critical. There needs to be some sort of repetition within 30 seconds of a key concept. There needs to be a reminder 60 to 90 minutes into the activity or after the activity to allow them to begin the process of long-term storage, which actually takes about 10 years to fully complete. And then if you have some sort of review in the morning, that actually will give you another 10% boost in retention. One of the things we did in our program too is we had Tuesday morning didactics and a Wednesday morning resident case-based teaching. It was a typical week for us, and what we commonly would do is try to use that Wednesday morning resident teaching case to be related again to the Tuesday afternoon topic, so that they were still getting more of those concepts reviewed the following morning. And then finally, make sure that you summarize clearly at the end of the presentation to hammer home the key learning objectives. That's a critical step that sometimes we forget. So questions, comments, I'd love to have your questions, and I think Emily will be able to collect those from you, and then we can go over those in the next, I think, 20 minutes or so that we have.
Absolutely. I'd invite everyone to go ahead and submit their questions to the dialog box, and I'll be able to read them aloud. We did get one question submitted right after we had kind of gone over the case study that you had presented, that typically you'd have everyone break into small groups. Our listener asks, did students read about TB and other background material prior to this case study, or that scenario that you gave us?
Yes, yeah, I gave them a PDF document about HIV or TB management with HIV patients that basically kind of summarized what are the key kind of diagnostic dilemmas that come up, and also the management of it, which includes, so like the medications that we use in TB, it says RHZE. A resident would have known what those drugs were if they had done the pre-reading. So when I introduced them in the key concepts, they were not like foreign, abbreviations to them.
Sure, that makes sense. We have a kind of a related question. Someone asks, you mentioned having learners prep ahead of time. How residents are so busy. How have you been successful in getting them to prep ahead of time? What does this involve for you?
Yeah, so part of it is that when they come to the learning session, if they haven't read and they're working on a team of residents, they find very quickly that they can't contribute as much. And so the small group learning was one way to kind of stimulate the sense that I really do need to come a bit more prepared. And we also would only pick like one article for them to read, and I would try to make it a review article so that it's something, and this is what the AFP journal is so full of and has great review articles. So asking a resident to read, a review article on the topic prior to coming was something that we found, I would say probably about a third to half the residents would look, it seemed like they had read because they had ready responses related to the paper that they had read. So half of them don't, which we know that's going to happen. But it's still, there's almost this peer pressure that develops over time. The more you do these types of talks, the more the expectation is, hey, you got to come prepared or you're going to miss out on some of the learning because you haven't been prepared to read. And we made it very clear, we expect you to read this because it's going to make your learning better. What we found, the feedback on this whole teaching style for our residents was incredibly positive, and they felt like they were not wasting time at all. I do want to comment on one of the questions I asked the audience was that, have you had residents complain about working too hard in your didactic session? And, I'm not sure how many of you had that happen, but is what started to happen with my lectures when I was giving these to the residents, is that I actually got feedback that a couple people answered back in the survey that it's like, man, it is hard. It is work when you lecture for us. And I was excited about that because, when they're busy working, nobody had time to text or fall asleep or anything because they were having to do stuff. And I thought that was the best compliment I've ever had of my teaching was you made me work too hard.
I could definitely see that. We do have another, and I know that several people had asked questions about how you ensure that people will do the intended reading ahead of time. So I felt like you addressed a number of questions just by hitting on that a little bit. Another person asks, how much engagement did you get from residents with the email prompt after didactics? Did you see that people, were reading, or kind of what results did you get from that?
Yeah, so we did not track that piece of it because we would send it out as an email, but we did start doing that Wednesday morning. Um, we actually started repeating the key concepts at Wednesday morning at the very beginning of that session that the resident was going to run from the day's lecture. We figured that that was another way for us to capture that recall piece um, with the morning after review. So we actually would just insert that in at the very beginning. So here's the key things we learned about yesterday in didactics, and we would go through maybe have like 2 slides that show the key concepts from the 2 topics that were presented, and then we move into the lecture. Um, and the residents understood. I mean, we taught them about the brain rules, and so they understood what we were trying to do. And I think the buy-in is different when people feel like you're trying to help me learn, so you're not wasting my time. That I think residents really responded positively to that.
That makes a lot of sense. I kind of was wondering, I guess you could really see that if you started off the residents by letting them know exactly what your goals were, that they're going to be more open to having that kind of active learning.
Mm-hmm.
We have another person who asks a related question. If we are unable to meet the next day for a morning review, would sending an email be an effective way to do that morning review?
Yeah, I think it would be. I think one of the things that I wish we had at the time was a way to send a text out to everybody, um, because I think people are so used to getting texts, and looking at their phone right away and paying attention to those things that would probably be the most effective thing if you could send out a group. And so we actually had text a group texting system that we could actually do, and that was one of the things we started to do was to just send out a group text in order to kind of get people's attention because people always look at their text. I mean, they never ignore that, and it would flash on the screen from me. Here's the key learning points from today. So that was one of the things that we were able to do through our paging system that we had, which was one way to kind of get around sending the email which may or may not be read that morning.
Yeah, that makes sense. Absolutely. We have somebody else who asks, how do you best manage a mixed group of learners when a small percentage may still need more basic knowledge and aren't ready for this advanced approach?
Yeah, so this is where the case discussion I think was so rich because what would happen is that the more senior residents, like for instance this case with TB and HIV, I had residents going to Kenya working in a hospital taking care of HIV patients with TB all the time when they were there. So they actually got very experienced at seeing these patients, and they would have their own stories, and so they became engaged in the teaching part within these small groups. A lot of times you'd hear them explaining to the junior residents, like, here's what I saw. And so with our typical didactic cycle, by the time they're in R3, they've already heard these talks as an R1 because we would repeat each talk twice during a 3-year period. And so the R3s were actually were actually helping teach and facilitate the learning, and the R1s and R2s were in the process of learning the key facts and concepts. So you're right that it may have been less new information, or it always was less new information for the senior residents, but they were reinforcing their own learning and their own knowledge by what they had learned. And then there was always things that came out during the discussion that would kind of feed the need for the senior resident with new things, new ideas, and that other people would share. So there was far more richness to the discussion because we had this multi-tiered layer of senior residents, the facilitator, the faculty, and junior residents working together.
I could definitely see that kind of effect being very, very helpful for that reinforcement, especially when they know that that's what that's doing for the more senior residents.
Yeah.
We have another attendee who asks, do you have any information about the value of block teaching sessions, a half day, for example, versus doing teaching sessions in shorter blocks over several days a week?
Yeah, I think a lot of programs have struggled with, like for instance, trying to do noon lectures because of the no-show rate is so high with people who get caught in clinical activities that they can't get out of. So I know many programs have moved to an afternoon of didactics where they could really block people out, get them out of their clinical duties, and get them into one place. So I think just for efficiency of getting more of your program there, typically we were able to get between 22 and 24 of our 30 residents in our lecture room on a typical Tuesday afternoon. And, we had to block them out of their work. And there'd always be a couple people on inpatient services that couldn't get away, or an intern on surgery or something like that. But for the most part, we were able to get about 2/3 of our program there, a little bit more than 2/3. But I think that we found that, and I think a lot of programs have found that kind of block teaching is the best way to get people there. I think it does present challenges with keeping people engaged if you don't use active learning techniques, because if you have people in a room for 2.5 or 3 hours and they're not actively learning, they are quickly going to zone out. So that's where I think this works hand in hand with high density learning happens in an afternoon every week, and it does help you kind of consolidate the work and the reminder systems into a little bit more feasible thing than trying to do it every single day of the week.
I can definitely see that. That just from the sheer difficulty level, that it's worth it to have it kind of blocked together. We're continuing to have a few, similar questions flowing in on how to do the AM morning review. One person asks just straight up, what is the content of the text that you send out? And another person asks, is there a best way to review in the morning? Would you ask questions, review cases? Does it matter how this occurs?
So what we would do is just send out the key concepts, because if they were present, they've already had a chance to engage with the cases. We did have, in fact, like the RCR content does have a post test for every single lecture that's on the RCR, which we've designed the RCR to be a interactive teaching model content for the lectures. We've really worked with the authors to do that, and we've had them use a post test. So a post test might be a way to trigger it, but it's very important that the post test have answers, that have explanations, that allow the learner to reinforce the key concept of what they just learned the day before. So you can use a post test like that would be one option. But for us, we just found that just sending out the key concepts again, I mean, all we're trying to do is trigger their memory to put this in long-term storage. We're not trying to grade them or reassess them in that morning. We're just saying, put this in front of your eyes so your brain does the work, putting this into long-term storage.
Yeah, I can definitely see that. I have quite a few other questions flowing in, but I will pause just for kind of a housekeeping note. We have a few people who are asking if the webinar will be available later, or if they could have a copy of these slides. And the answer is yes, we are recording this webinar. So we will make that available on the STFM website. If you go to online courses and then click over to webinars, we do make these available, or you can also go straight to our STFM YouTube channel to find these Faculty for Tomorrow webinars. So this content is being recorded. So I also have a few people who asked, do you still use lectures, or is everything that you do case-based for your residents?
Well, I guess defining what a lecture is. I mean, basically, I try not to lecture. I mean, like doing this talk today feels like a lecture because we're not all in the same room. But if we were in the same room, it'd be very, very different. And yeah, because I think to me, just straight lecturing, it's like giving a plenary session where you just talk at people. The learning retention is quite low, and I don't want to waste their time. I would much rather, I have much more fun engaging people with material and have them problem solve right in front of me to see how they're learning and see how they're answering. Not only can they learn, but I can assess how they're learning and what they know even by listening into those discussions. So it is, I just prefer not to lecture.
Mm-hmm, mm-hmm. Yeah. Well, I think that this is a somewhat related question, I think, with this kind of a new active learning concept that you're talking about here. One person asks, How do you use the brain rules to teach more abstract factors like patient-provider engagement?
Hmm. So that's where you have to come up with the concept. So when you think about patient-provider engagement, what are the key concepts about how what makes that interaction work? And I mean, just off the top of my head, since I talked to this about with my medical group just the other day, like for instance, trust is a very, very key concept in how we engage with patients. And so if you think about what are the ways that we engender trust within our visits with patients, and that's a concept that we want people to keep in mind. And then and trust is tied to things like active listening, patients feeling like they're being heard. Um, there's a sense of empathy and warmth between you and the patient. Um, lack of judgment. So there's different things like that. Those key concepts would be the things to focus on, and then so what you're doing, and then you would give them a case to show, or maybe even a video of an encounter where the person was distracted, not where the patient loses trust in the provider because of distraction, for instance, would be a good example. So that kind of learning, especially, I mean, I've seen this a lot with patient engagement type of teaching, where they use videos to demonstrate kind of bad and good behaviors, and that's very powerful. People don't forget those very easily when they've seen it on video.
I can absolutely see that kind of demonstration, even if it's not the highest quality video. Sometimes I think those even
Right.
stick better. Sometimes
Your iPhone will work.
Right, right. We also have a few questions related to, again, the logistics of the pre-reading assignments. One person asks, how far ahead of time did you provide the pre-reading? And another person has asked, how much time do you expect overall for the residents or learners to spend on that pre-reading assignment?
Yeah, so we actually, what we did is exactly the same thing we're doing on the RCR, which is we try to provide one article, and we would send it out. Usually our lectures were on Tuesday, so we would send it out on Friday. So we gave them about 5 days, a reminder. So here's next week's topic, and our topics were built out for the entire year, so anybody could look ahead and see what our lectures were going to be and what the topic was going to be. So they had that in advance, but then we would send out the actual PDF file. So here's the topic we want you to read, because even though they could get access to it, for instance on the AFP journal, we would still send it to them on their email, so they could just open it up and read it, instead of having to go online to look for it. But we'd send them the file so they could read it over the weekend, within 5 days of doing the talk.
Yeah, okay. And I'll just clarify for any latecomers, by RCR, you're referring to the residency curriculum resource, which
Right.
is something that you're the senior editor there
Mm-hmm.
with that resource for residency programs,
Yeah.
family medicine content.
Yeah. And probably a lot of listeners don't know, but that the whole RCR project was started because what we wanted to do is transform how we teach as best we could, and those of us working on the project felt like, well, if we can provide content that's already built to be engaging and save a tremendous amount of faculty time to build the stuff yourself, it's much more likely to get used, and we could provide make faculty life easier for the lecturers, but also design the lectures in a way that kind of really stimulates and engages more resident learning.
I can definitely, yeah, I agree. That makes a lot of sense for the goals of that, to build it in that way. We do have this is kind of an interesting question. It's related, but it asks, our residents evaluate presenters, which now seems like it might not be the most valid form of capturing the effectiveness of learning. How do you evaluate your teachers or presenters at your program?
Yeah, so one of the things that we like at the end of the year, we would basically go back and do a survey, like how about effectiveness of didactics, and we would have residents would rate individual faculty on their teaching effectiveness. So we didn't ask. We try to phrase it that way, like how effective of a teacher are they when they're doing didactic sessions or bedside rounds or inpatient rounds. So we asked specifically about the didactic sessions, and that gave us a chance to see people who were who use more interactive techniques, would always get better uh, feedback as far as how effective the residents felt they were than people who were just using the typical barrage of slides. And most of our faculty stopped doing that after about 2 years because they all heard the brain rules presentation from John Medina. We all spent the whole afternoon talking about it, and everybody got very enthusiastic about changing the way we teach. And once you do it several times, it feels so much more fun to teach that way that it's just really hard to go back to throwing up 45 slides and saying, "Here, listen to me talk."
Yeah, I could see that for sure. Even with this webinar series, we've been kind of including additional different ways of audience engagement as we proceed. Even though it's hard to do, small group discussion is an element that it's difficult to give in a national webinar like this. But audience attention and retention is just demonstrably better when you're kind of engaging with the audience as we are now with the questions that are coming in. That's about all of the questions that I've received so far. I think we've covered the majority of them. There were a few that were kind of on similar content. I do want to let you all know that we are going to be recording the webinar. We are recording the webinar, and it will be available on stfm.org under online courses and webinars within 24 hours of this live event. We typically get it up by the end of the day. So thank you for taking the time to do this, Dr. Tuggy. I really enjoyed hearing your techniques for keeping learners engaged and motivating them to apply and retain what they've learned. So thank you.
You bet. Thank you very much for coming.
Yes, absolutely. We had a good audience today, even on a Friday afternoon, so I really do appreciate that. We will be sending out a brief post-webinar survey via email in the next couple of days so that we can continue to serve you better with our presentations and learn how we can even more effectively give these sessions. So thank you again for joining us for this Faculty for Tomorrow presentation, and have a great afternoon, everyone. Thank you.
Okay, bye-bye.